It was interesting where I went into this street and talked to people and asked them, their thoughts on hormones and their thoughts on menopause and things. There were a number of women who said, "Oh, no, I just think I just want to do menopause naturally."
Mhm.
And I nearly feel like it becomes like a badge of honor to do it naturally.
Mhm.
And, I just wonder how we've got to that point where women feel that that is actually the superior choice.
I mean, to me, it's lack of education. When I hear a woman say that, I think, does she know what menopause is? Because the video you did was so insightful, is like going back to the basics of, do you know what menopause is? I mean, the definition of, again, of menopause is 1 year with no natural periods, but it's actually a profound hypogonadism. It's a profound decrease in the function of the ovaries. And once women start understanding that this is like a man's testicles stopping working. We never tell a man who has low testosterone in his 40s, 50s, and 60s that that's natural. Erectile dysfunction is natural, and Viagra is one of the top selling drugs in the entire world. So the other thing I like to do is hold up the lens and say, okay, fine. If women should do it natural, let's apply it to men as well. And then we say, "Oh, we treat their issues associated with aging. We treat their low testosterone. We treat their erectile dysfunction. We treat all of these things in them, so why aren't we doing it in women?" And so it's like, I love holding up because ultimately, I don't care if people take hormones or not. Me and the other advocates out there, it's like, your body, your choice, but your body, your choice with education. Understand what's happening, and then you choose.
Dr. Kelly, I'm so delighted to have you back on the podcast. How are you?
I'm so good. Happy to be here in person.
Amazing. So let's just get straight into it. We've had a few questions where people are asking, what actually is the point of women having a menopause? Is there like an evolutionary benefit to this thing?
Yeah. Yeah, no, it's a super interesting question, and I dove into it because my second book, which is way more about menopause and hormone therapy, is coming out later this year in September, I believe. And so I looked into it because one of the things that people talk about is, like, people use it as a justification, I think, to not take hormones because they think that there must be some sort of evolutionary benefit to living without hormones. And no, not that we can think of. And the other big myth that I love to dispel is people will always say humans and four whales are the only people to go through menopause. First of all, menopause means no periods in 1 year. Most mammals don't have periods. Most mammals self-resorb their uterine lining. They don't bleed, right? So you can't really say other animals have menopause or not because they have different bodies and uteruses than we do. Okay, so there's that. If you take mammals and you have them live in captivity, which means clean water, no predators, antibiotics when they get sick, right? If you take care of them, they all live longer than their ability to reproduce, which we're going to use that as a marker for menopause because they don't bleed, right? So, okay, well, we're well preserved. I actually wanted to name my second book Living in Captivity because we are being well preserved now, right? Antibiotics alone have extended the average life expectancy by 26 years. It's crazy. And we don't think, because we are living now and not before, we don't think of the fact that we are aging as a population longer than we ever have. And that's brand new, right? Like we're just figuring out how to do this. And that's why I think Gen X is so powerful because we're seeing people do it poorly. And we're like, what if there's a different way? What if we can prevent frailty in the first place? What if we can prevent heart disease, prevent osteoporosis, prevent dementia? And in order to do that, you have to preserve the body a little bit better. So this whole like evolutionarily benefit, yes, in the fact that from yeast species to fruit flies to like all species that reproduce, there seems to be an evolutionarily benefit to living longer than you can reproduce. Reproducing is very expensive as far as resources go. So all of these species will live a little bit longer than their ability to reproduce. We don't call it menopause. Fruit flies don't go through menopause, but they live a little bit longer. You take the fruit flies and you put them in captivity and they live exceptionally longer, right? So I think of humans as we're humans in captivity. Now we have the ability via sanitation, clean water, antibiotics, trauma surgery, exceptional cancer care. We have the ability to live 40 years past our reproductive ability. And that's where the frailty comes in, because the hormones work everywhere in our body, not just reproduction. So I think when people oversimplify it and they're like, menopause is God's gift to humanity because now we can take care of the grandbabies and not worry about being pregnant. I think we're not understanding actually how our bodies work, and the fact that we're kind of fake in living to 90 as a population, but we all want to do it, right? So it's like, if you wanted to truly be natural, we wouldn't be living that long. If you look at Victorian England, where they kept track of the wealthiest men for death records, right? Because nobody else, paper was expensive. They weren't keeping track of people that weren't important. The most important people, they kept track of birth and death records. Average age of death for men, the wealthiest men, was 47. And there are some data in women where they had babies into their early 50s, death was 57. So this whole, like, is it natural to not take hormones after menopause because it was meant to be? I would argue living to 84, which is our average age of life expectancy in developed countries, that's not natural. But we all want to do it, so let's do it well.
Agreed. And what about the people who say, well, HRT isn't a natural thing. I'm just going to let my body do it naturally.
Yep.
I mean, can you just extend that a little bit further and talk to the fact that we are using hormones ultimately that are pretty identical to what our body makes?
Yeah, and I'll even take it one step further. The social psychologists have researched this myth of natural, or what they call the naturalistic fallacy. And what that is the belief that if something is natural, it's therefore superior, or it's therefore better, or it's therefore the just and right thing to do. And that's just a thought error, right? It's like anthrax is natural, you know, drinking water that has feces in it is natural in nature, right? So it's like, natural isn't this utopian Mother Nature pristine environment. We have trauma surgery because falling and breaking a hip might be natural, right? So it's this, I like to just say, yes, the hormones we use now are exactly what our body makes. And check your bias. If you're living your life by only doing things that are natural, why do you have on shoes? Why do you put on sunscreen? Why do you get dental care, right? It's all unnatural when you start picking at it. And so you can you can open people's eyes to their bias, because again, we use that naturalistic fallacy to withhold care. I believe withhold preventative medicine from people's bodies.
Well, even the word natural is used, for example, in the world I am in, which is skincare.
Mhm.
Like, and lots of people will put the word natural on skincare and it improves sales. So clearly there is like a subconscious bias that people, you know, gravitate towards a product that says something. But what is the definition of natural? You can't define it. It doesn't actually mean anything.
Yeah.
So lots of patients will say, "Oh, I like to use natural skincare," but what does that even mean?
Yeah.
So it's definitely a word that has a very emotive thing for people in very many realms.
Yeah, I mean, it ties into purity culture, right? It ties into all, like, what you should do, and it kind of takes away the ability to think critically about things, because you're kind of putting pressure of doing it right by this belief, again, in the naturalistic fallacy. So I like to point that out. Like, yeah, we've researched people's, like, belief in this, and that's what we're all doing. Say you can put natural on a candy bar and charge more money for it. And that word natural in the health foods world actually is meaningless. It's less meaningless. Like, the word organic is more defined.
Yes.
The word natural is actually meaningless. It's marketing.
It was interesting when I did my little piece where I went into this street and talked to people and asked them, their thoughts on hormones and their thoughts on menopause and things. There were a number of women who said, "Oh, no, I just think I just want to do menopause naturally."
Mhm.
And I nearly feel like it becomes like a badge of honor to do it naturally.
Mhm.
And, I just wonder how we've got to that point where women feel that that is actually the superior choice whenever the data and the research clearly shows us that it's not, in
Yeah.
terms of not only longevity, but living well for longer, living healthier from your bones, from your heart, from your bladder. Everything is probably going to be improved
Mhm.
by taking hormones. And yet people seem to feel like, I don't know, there's like nearly like this, that makes them, I don't know, that it proves they're more resilient or something by not taking
Yeah.
hormones.
I mean, to me, it's lack of education. When I hear a woman say that, I think, does she know what menopause is? Because the video you did was so insightful, is like going back to the basics of, do you know what menopause is? I mean, the definition of, again, of menopause is 1 year with no natural periods, but it's actually a profound hypogonadism. It's a profound decrease in the function of the ovaries. And once women start understanding that this is like a man's testicles stopping working. We never tell a man who has low testosterone in his 40s, 50s, and 60s that that's natural. Erectile dysfunction is natural, and Viagra is one of the top-selling drugs in the entire world. So the other thing I like to do is hold up the lens and say, "Okay, fine. If women should do it natural, let's apply it to men as well." And then we say, "Oh, we treat their issues associated with aging. We treat their low testosterone. We treat their erectile dysfunction. We treat all of these things in them, so why aren't we doing it in women?" And so it's like I love holding up because ultimately, I don't care if people take hormones or not. Me and the other advocates out there, it's like your body, your choice, but your body, your choice with education. Understand what's happening, and then you choose.
Kelly, I'd love actually for you to talk to us a little bit about testosterone and low testosterone in men, because I know that as a urologist, you look after both. How does that present? And does it present in a similar manner to some of the symptoms we see in women with low hormone levels?
Yeah, actually, it pretty much does. So, the most dramatic way to see a man deal with low testosterone is prostate cancer treatment. So, we actually give them medication that drops their testosterone really low. Those men say, "I'm lethargic, I'm tired, I have no more get up and go, there's no libido, I'm gaining weight around the middle, I'm losing my muscle, I don't even want to go to the gym," and then hot flashes, really bad hot flashes. And those men are some of the most sympathetic men towards what menopause is. They're like, that's when you take your hormones and you drop them. And same with women. That's when you take your hormones and you drop them. One of the problems I think with low testosterone or and low hormones is like these hormones are in every cell in your body. So it can look different in everybody. If you're like, what does a broken arm look like? That's very clear in all humans. A broken arm looks like a broken arm. But for you, it might be, well, your hormones are affecting your brain more. This other person's hormones are affecting their heart more, right? So it presents different, and that can be vague for some people. And the symptoms of low testosterone can be vague, like decreased energy, decreased mood, decreased muscle mass, right? It presents differently in everybody. It doesn't mean we shouldn't treat it. It just means we're all individuals, and it's not as cut and dry as like if you have a piece of wood in your eye, everybody presents the same way with that.
And in terms of, so I don't know if it's the same in the US. There's definitely in the last sort of, I would say 2 to 3 years, been a real interest among young men, older men about testosterone levels,
Mhm.
what their testosterone, like I have to say, in the previous sort of 20 years of my career, I'd really never had anyone as a male present asking for testosterone levels. And then suddenly in the last 2 years, lots of men asking for me to check their testosterone levels. Do you know where that's come from? And is that something that as doctors we should be doing a lot more regularly than we do?
Have you ever heard I'm gonna answer your question legitimately, but have you ever heard a man say, "I'm just gonna deal with my low testosterone naturally"?
No, I have not, to be fair. They come and they tell me, "Oh, I wanna have my testosterone checked because my friend who I go to the gym with had his checked and it was low and blah, 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 and I want you to check it and replace it." Yeah, no
So
one's talking about doing it that.
nobody's talking about doing it naturally, right? So it's fun to hold that mirror up to be like, "Women, what are you doing?" When men are suffering, they know that there's solutions, they know it's okay to be treated, they know they're gonna feel better, and they know that it's safe. Right? So it's like I wanna get that into the women's head too of like, yeah, it's the same stuff, like low hormones, low hormones. But no man's like, I think I'll just like learn how to breathe more deeply.
Go and do some Pilates for
Right.
your low testosterone.
Exactly. Like exercise is fantastic, but it will not replace gonadal function. So the testosterone in men, it's been growing in America for quite a while. The exciting news about testosterone in America is March 1st, the FDA just announced they're going to take off the cardiovascular risk from the boxed warning, which is fantastic because one big myth of testosterone is that it might be dangerous or it might increase your cholesterol or it might increase your cardiovascular risk. That has not been shown to be true. So the fact that the FDA is correcting misinformation on testosterone, I'm very excited because they need to correct the misinformation on vaginal estrogen, and I'm hoping that they will do that. But again, I think it goes back to men want to feel good. They want to be optimized. They have in the male culture, it's like to be fit, to be vital, to have a healthy sex life that is normalized, appreciated, and supported. That's not always true in the women's health domain.
And is there a danger from having too high testosterone or taking too much testosterone as a male?
Yeah, I mean, I think it's a fun myth because even though women who are on hormones, they'll be like, give me more, but give me more." This myth that like more is better, right? Whereas in medicine, it's like if the blood pressure medication's working, you don't give more, right? If your insulin's controlling your diabetes, you don't give more, right? So there is like supraphysiologic, meaning giving more doses than your body naturally deals with. A little bit's okay for some people, but to a point, you're going to start getting side effects. Just like if you give, you know, coffee's good, more is not always better, right? Like there is a point where you can have too much. And we see that in the testosterone world. I see that in women who are on hormones. They think more, 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 more. Or they think hormones might be a cure for everything. They are not.
Yeah, absolutely. You touched on vaginal hormones there. And as we know, the same in Australia, we've got this terrible piece of paper that comes inside the box. Um, and sometimes, women can be a bit overwhelmed in their consultation and they'll come back and say, "Oh, actually, I didn't take that because I read the brochure." And I'll be like, "Remember we talked about that?"
Mhm.
Um, can you explain what is going on with that leaflet and why it is actually not relevant to vaginal hormones?
Yeah. So vaginal hormones are very, very low dose. They don't go in your bloodstream to any appreciable amount. And it's very, very safe skincare. So even when we talk about replacing or hormone therapy for menopause, even that's higher, and it's not high compared to birth control pills, right? That's higher than vaginal estrogen, which I just call skincare for down there. It's like not absorbed. But after the Women's Health Initiative came out in 2002, our FDA, the American FDA, put a label on any estrogen type. Didn't matter the dose, didn't matter the route, didn't matter the indication, just having to do with estrogen got the warning. So inappropriately applying this to everything. And so it's also on vaginal estrogen. So the vaginal estrogen packet will say this can cause blood clots, cancer, heart disease, and it doesn't say possible dementia. It says probable dementia. So anybody who knows words, that's worse than possible dementia. And so I tell my patients, I had to say, listen, if you read leaflets, you're going to read that this is what it says. It is wrong. I'm sorry you have to choose between me and the FDA. Now, the FDA's had some controversy in America, so most of my patients are happy to believe me over the FDA. But my friends did a study and they said of women who get a vaginal estrogen prescription, about 20% still won't use it because of the warning label. So physicians have petitioned the FDA twice to take that warning label off. FDA has still not done it. So we have a citizens petition in America. If you go to letstalkmenopause.org, you can sign it. Americans only can sign it. But if American can get those labels off, I think it'll follow suit for Canada, for Australia, for all the other countries that have that label on there.
So, if someone starts vaginal hormones, how quickly do you think they would usually see an improvement in their symptoms of, dryness or that sex is painful? What's the time frame that people could
Yeah,
expect?
we usually tell people 6 to 8 weeks because, and I tell people it's literally building healthier skin, right? So it takes some time to do that. It's not just like a sexual lubricant where it's going to be moisture tonight. So it really does take a little bit of time, but in the grand scheme of things, that's not that long. And the other myth is that you can stop taking it then. And it's actually like, well, I used sunscreen last August. What do you mean I have to use it now? It was like, no, you have to keep using it to get it to work. So that's another myth.
I'm so glad you said that because I have to say that is one thing that I just come up against repeatedly. I'll say, you haven't had a prescription for that in a little while. Are you still using that? And they're like, oh, yeah, no, I kind of stopped using that. Will I start that again? I don't know why. It just seems to be people just seem to, once they feel a bit better down there, they kind of seem to forget about it
Yeah.
until it starts to get
So
really
then,
sore
yeah.
again.
Yeah.
And then we end up back in a vicious circle.
Yeah, some people do moan about it, and I get it. Like, we're busy. Like, self-care is not always the number one priority. But I'm like, there's lots of other maintenance things we do all the time that we don't whinge about. Like, I wore a seatbelt last September. You mean I have to keep wearing a seatbelt? Like, I have to keep flossing, right? So it's like we do things I have to drink water today. I drank water yesterday. Right, so I just point out those inconsistencies in people's health behaviors, and then you're like, "Okay, yeah, well, a little bit of skincare down there." And, we all do skincare on our faces every single day. This is just a little bit more skincare.
Um, I was attending a presentation at the World Menopause Congress, and it was for the vaginal DHEA product, which I have to say I really love and love to prescribe. And they were talking a lot to how we've actually got testosterone receptors at the entrance of the vagina, on the clitoris, on the trigone of the bladder. And do we know if using those intravaginal products is actually getting to those places as well?
Yeah, so I love that product too. It's just so much more expensive in America, so I don't use it as much as vaginal estrogen. Um, there hasn't been a lot of research on how much is improved. The thought is that it's local, just like vaginal estrogen, but the vagina and the bladder share a wall. I always joke that they're condo mates. So we do know that those hormones can penetrate into the bladder, and the bladder is very responsive to hormones. Dr. Louise Newsom's actually presenting some posters this week in Perth at the Australian Urologic meeting, looking at the role of systemic testosterone decreasing bladder issues in women. So we know 1 in 3 women will have issues with bladder leakage. Bladder leakage is one of the top reasons that women go into nursing homes. It's one of the top reasons you get up at night to go pee and you fall and you break your hip, right? We never talk about bladder leakage, but it's actually incredibly common and can be debilitating. I see older women that they can't leave their house. They're too worried about the bladder leakage. So it's like, why aren't we looking at natural solutions? And again, it's not going to help everybody. Some people do need physio, some people do need some surgical procedures, but these are safe hormones our body naturally makes. We're just simply living longer than our ovaries. And going back to living longer, it's like, do we ever tell anybody, I'm sorry you outlived your eyes, you don't get glasses? I'm
Well, you
sorry
have
you
to keep your cataract.
Yes, I'm sorry you outlived your teeth. I'm sorry you outlived your hearing. Like, why are we making this crazy exception for ovaries? I think it's probably because we can't see them,
Yeah.
right? Because they're hidden. If we could watch a man's testicles shrink over time, it's a lot more obvious what's going on. We can't see our ovaries.
I think people also assume that your ovaries are just about having a baby,
Yeah,
and
right,
then
yeah.
because no one's having a baby when they're 60, well then why would you need them? And so we're just caught in this paradigm where everyone's always thought of these hormones about sex and babies and puberty and nothing really else.
Yeah.
And then until we get the message out there that actually these hormones are for every cell in your body, I think we're going to struggle to
Yeah.
to get that over the line.
Well, I think some researchers are gonna put me out of business in a decade, which is gonna be fantastic. So it was in 2024, I was sitting at South by Southwest, which is a big kind of thought leadership conference in Austin, Texas. And, me and my team, and we all talk about, the menopause and education and hormones. We think we're kind of radical at this point because 10% of women are on hormones, right? Where there's a lot of work to do. So I'm sitting in the audience. This group of PhD researchers goes up on stage and they say, what if menopause is optional? We're working on that. We're figuring out why ovaries do end in the mid 50s. And there's likely will be a medication that will keep them going. So, number one, it might be possible to have a baby when you're 60 plus. Do you still want to have your period? Right. And number two, even if it's not a fertility thing, figuring out how to keep the hormone producing cells functioning. And I was simply blown away because I'm like, when that research comes to fruition, I'll be out of a job. It's like you don't even need to take supplemental hormones. We'll just keep your ovary going. Right. And so it's like that's the next step of like, I'm not even all that crazy in saying let's bring back in the hormones we're making. These people are trying to figure out how do we just keep the ovary going a little bit longer,
Yeah.
which is brilliant. That's what we need to do.
I attended a conference in Monaco about 2.5 years ago, and it was exactly the same. There's a whole female team presenting, and they were looking at how you could preserve ovarian function, and seemed to be making really pretty amazing progress. They were like, this is what the future is going to be, that we will be able to do something that makes your ovaries continue to function.
Yeah.
So that would be pretty.
Yeah, and so I, like, looked to my friend, I'm like, "I think we're the radical, thinkers," and it's like, "Nope." We're like, these are the big, big, big thinkers in the field.
Kelly, I want to move a little bit sideways and talk about a group of patients who I think are sort of silently suffering in the background with a diagnosis of interstitial cystitis. And these patients are in hell. I have patients who have this condition, and they tell me they're like literally sitting in the shower at times, having to run a hot shower over their body for hours on end to try and relieve the pain and the discomfort. They're having to always have like a hot water bottle or a hot pack on them. Like, these symptoms of this bladder irritation are just off the chart. And obviously, you and I have discussed previously, potentially are some of these patients being missed in terms of being given vaginal hormones, etc. But can you explain a little bit about what that condition is?
Yeah, and thank you so much for bringing it up because I think these people are hidden and suffering often in science, just like you said. So interstitial cystitis is a chronic this is how it's described, a chronic incurable disorder of the bladder, usually associated with inflammation and pain. There's no blood test for it. There's no x-ray for it. It's supposed to be a diagnosis of exclusion, right? So you rule out bladder cancer, you rule out a urinary tract infection, you rule out a hip issue, right? But often what I see, and a lot of friends who are female urologists or take care of women in their pelvis, is that it's kind of just thrown on people. Like, I don't know what it is. It's probably interstitial cystitis. And then these women will go online and they'll say, oh my gosh, I'm not allowed to eat all of these foods. They become very food restrictive, trying to figure out what's inflaming their bladder. Sometimes that does help. I always tell women, like, is it possible you don't have a chronic incurable disease? You just have a sensitive bladder? And I'm like, what do you like better? And they're like, I like the idea I just have a sensitive bladder to some things. I'm like, okay, well, my skin is sensitive to something. Doesn't mean I have a chronic incurable disease, right? It's just like this. I always say it's like you're adding bricks to a backpack for women, and they can never take the bricks out of the backpack. They're stuck with this label of something that I think 9 times out of 10 they don't actually have. So I'll see women just with recurrent urinary tract infections. They've been labeled with IC. I am not, to clarify for everybody, I'm not saying it doesn't exist. I'm not saying it's not real. I'm saying we're not being curious with a lot of women, and we're just throwing a label on them when a lot of times they have other things going on. They didn't get a thorough workup. They didn't meet with a pelvic floor physical therapist to look at musculoskeletal options. Um, Certainly hormones have to be part of the discussion. I have so many women and they'll be like, "Oh, my interstitial cystitis hasn't bothered me in 20 years since I started vaginal estrogen." I'm like, "How about get rid of the idea that you have interstitial cystitis then, right? You just had genital urinary syndrome of menopause that was treated with hormones and now you're symptom free." But they carry the bricks in the heavy backpack thinking they still have this. And I think this is, for people much smarter than me, like the psychological burden of carrying around a diagnosis. Like, we never take diagnoses away from people,
Yeah.
right? Like, it's a kind of a psychological crazy town at some point.
Yeah, we're just adding to the list on their medical records.
Yeah.
In terms of bladder cancer, again, a cancer that's not talked about a lot. What are the risk factors, and what are the things that we can do to prevent and reduce the risk of us getting bladder
Mhm.
cancer?
Don't smoke. Smoking is the number one biggest risk factor for bladder cancer. So the metabolites of cigarettes, and I mean, for anybody, smoking cigarettes, marijuana, vaping, like all of the toxic chemicals get metabolized and then basically hang out in our bladder before we pee it out. So that's how the lining of the bladder gets those chemicals. That's the number one risk factor. Being male is actually a huge risk factor. Women have a lot less bladder cancer, but women get diagnosed at later stages. Why is that? We don't know for certain, but it's likely we blow her off. She says she has blood in the urine. We say she has a urinary tract infection. She has blood in the urine. We say, well, maybe it was just your period, right? We blow them off more. So by the time they're diagnosed, it's a much more invasive level than when a man comes in and he's like, I got blood in my pee, he gets a workup, right? Women get ignored. And I've seen it in my practice, blood in the urine for half a year, for a year before they actually get referred to a urologist for bladder scope, CAT scan, and actually see it. Now, that said, the majority of blood in the urine is not cancer. But I always tell people it's kind of like blood in your poop, right? It doesn't mean everybody has colon cancer, but we got to do a workup to find the people that do.
On Sunday morning, when I was out walking at Terrigal Beach, which is a local beach, I kept crossing paths with a number of women who all had vests on, just like me, weighted vests. And we all gave each other a bit of a knowing look because these have become very, very popular in peri and postmenopausal women. You might not know what rucking is, but basically what it is walking with either a weighted vest or a weighted rucksack. I personally opt for the weighted vest because I find it very, very comfortable and very, very quick to put on. So for peri and postmenopausal women, there are definitely a number of health benefits that you can gain from walking with extra weight. One of the health concerns that many women have at this stage of life is developing heart disease. And unfortunately, we know in the postmenopause, the rates of heart disease for women really start to accelerate. So why might rucking or walking with weight change that? Well, basically, whenever you're walking with additional weight, it increases your heart rate more, and it basically makes your heart exercise a little bit harder. So hopefully making your heart a lot more healthy. So that's one of the benefits of rucking in comparison to standard walking. So if you're intrigued and ready to start rucking, my recommendation would be that you start low and go slow. So start by choosing a weight that is 5 to 10% of your body weight at maximum, and take it slowly. Go for maybe a 10 to 20 minute walk at first. Don't decide to go on a 5-hour hike the first time you strap on your weighted vest. So we've been chatting to our friends at Rucksack, and I've got a special discount code for you. So if you go to their website, which is www.rucksack.com, so RUKSAK.com, and use the code Shauna15, so that's SHAUNA 15, you're going to get a 15% discount. So whether you decide to go for a vest or whether you decide to go for one of their backpacks, either way, you're going to get 15% off. Now, let's get back into the episode. Can we change gears again?
Yeah.
Let's talk about sex.
Wonderful.
Okay. I know it's your favorite topic.
It's a fascinating topic. It's so interesting.
So let's talk. I know you're a urologist and you're interested in the whole person, but when we think of urology, we think of pelvic organs. But I want to talk about the brain side of sex, and I want to talk about libido.
Mm-hmm.
Tell me, what on earth is going on with women's libido?
Yeah. So libido, no adults get adult sex education. We get a crappy disease and pregnancy prevention plan when we were younger. We never learn how to talk about it. We watch Hollywood films. We might watch porn. We get a very skewed view of how our bodies actually work. So Sigmund Freud kind of wrecked it for us, as he did many things. And he called libido appetitive, which is a fantastic word. But appetitive means appetite driven. And so if you don't eat, you're going to get more hungry. If you don't drink, you're going to get more thirsty. If you don't sleep, you're going to get more tired. Those are appetitive drives. And he said sex is an appetitive drive. For most people, if you don't have sex, you don't want more sex, right? And so women sit around saying, well, I don't want sex. I guess this is how it is. Now, how our body actually works is the responsive desire is like, no, you shouldn't have sex 24 hours a day because you got to have a job and you got to raise some kids and you got to get some sleep, right? It would be destructive for you to want sex all the time. And there are some people who do have that high appetitive drive, and it can be quite bothersome to them. So how our bodies work is we say, you know what, you're focused on other things. If you put yourself in a place to be receptive, to be open, to be surrounded by sexual cues, it's the sexual cues that actually prime your body for saying, all right, let's prep for having some sexual activity. Those sexual cues are going to be different for everybody, but it often means being in a relaxed state. not chasing around trying to get 10 things done, right? Your body needs to be relaxed, to be receptive, to be open, to be able to focus in the present moment, to be focused on bodily sensations, because it's the combination of the sensations in the pelvis and the brain primed together that makes the best orgasm.
Okay. And so I mean, clearly then it's a very complicated thing to say why women in the peri and postmenopause are struggling with libido
Mhm.
because it's clearly not just a purely hormonal thing.
That's right. Yeah, it's complex, right? Because we're complex. We're complex things. We wouldn't want to be otherwise. We aren't bacteria. So sex is biopsychosocial, which means it's a little bit biology, a little bit psychology, how our brain is thinking, and then a little bit about how we're socialized, right? Are you allowed to be sexual? Who's allowed to be sexual? Who's allowed to be sexual more than other people? Like, how are we cultured, right? Who's allowed to have their orgasm prioritized in a sexual event? The biology part is really where perimenopause and menopause kicks in. And I always joke, like, I got into menopause because of sex, because I really wanted to understand when women said, my sex drive went down with perimenopause, menopause. What did the research say? Now, again, because we're complex, not everybody's sex drive goes down in midlife. Some sex drive goes up, probably because they're more confident, they give less shits, they know they can't get pregnant, they're in a partnered relationship that is wonderfully caring and explorative and like sex positive, right? So it is a stereotype to say everybody's libido goes down. Some stays the same, some gets better. But there is a role, again, estrogen and testosterone work in the brain. That's where libido comes from. Multiple areas in the brain too, not just this little box labeled libido in the brain. And so it is more of a myth to say testosterone is the only hormone for sexual desire. I have tons of women, you throw an estrogen patch on them, their hot flashes are done, their heart palpitations are done, they're sleeping better, their mood's better, and the libido's allowed to rise naturally because she's just simply feeling better,
Yeah.
right? So it is wonderfully complex, but it is very real if you notice that your sexual function is changing in midlife.
So I kind of feel like I see a number of different, you see patterns among your patients. So I think one of the patterns that I see are people who are very happily partnered, they're very loyal to their partner, but they've got a lot of guilt because they just can't be bothered.
Mm.
I had a lady who I have to admit she did make me burst out laughing because she said she'd rather have a warm ham sandwich than have sex. She said she just couldn't be bothered.
Mhm.
She's like, "Just leave me alone. Let me watch my Netflix show." But a lot of women express a huge guilt.
Yeah.
They'll say, "I feel so bad for my partner." And sometimes I'll say, "Well, do you have sex?" And they say, "Oh, yeah, I do, but like I don't want to have sex
Right.
at all." Or it's uncomfortable. They kind of put up with it
Mhm.
because they feel like that's the thing that you should do.
Yep. Yeah, yeah, yeah. What we call, I mean, there's so little research in it, I think, because we don't prioritize women, but this like um duty sex is what they
Mm,
call it. Or, you just have to do it to keep other people happy. Now, some people do it out of love, but some people do it out of like, I don't want this relationship to end. I want to prioritize it. So a good sex medicine doctor they're just curious people, right? Because if somebody says, I don't want to have sex, that could be 12 different reasons why. Is it because of pain? Is it because you never had great sex in the first place? Or is it because the sex was great, but now really the idea of it, and we have to then think more about dopamine receptors. We have to think more about hormones, right? And then there's the people who simply say, I want to want. Okay. Versus the people who are like, no, I'm not thinking about it. I'm running a business. I got kids. But when I am in that sexual context and I know how to focus on my pelvis and I know how to relax my brain, we have a wonderful time. I just need to prioritize that in my life more than I have been doing. So it's wonderfully complex. There's really help for everybody. The International Society for the Study of Women's Sexual Health, which is a mouthful, but it's the ISHWISH conference. It just happened in Atlanta in the States this week, and they're coming out with exciting processes of care, specifically looking at orgasm. That's kind of we've done a lot more work on desire than we have with orgasm. So that's gonna be the kind of the exciting new thing. I can't wait for them to publish that paper, probably still another year or 2 out from that, but they're starting to talk about in a more scientific way instead of just blowing off like, "Oh, you can't orgasm? Drink wine." right? And instead of like, no, 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 this could be biologic, it could be psychologic, it could be sociologic. Let's look at orgasm and how to help women achieve that.
Have you got any resources or, I don't know, websites or apps or courses that you think are helpful for patients?
Yeah, as far as like like orgasm, yeah. So a very old book, she's unfortunately passed. It's by Betty Dodson. It's called Sex for One. And that's really understanding your body, how orgasm works. Becoming Clitorate by Lori Mintz is fantastic. I think that book is still in print. OMGyes.com is a great if video doesn't turn you off and you really like it's sex is hard, right? Because you can't with doctor, I have heart palpitations. The doctor can put the stethoscope on the heart and understand that. But when somebody says, I don't like sex, you're like, that's a black box. I don't know what you're doing in there, right? Are you rubbing elbows? So if you want more video how to, OMG, yes is useful. Make Love Not Porn is amazing for sex education, just normalizing sexuality for normal people, normal bodies. And for people, they have videos and stories of people with ostomies. They have videos and stories of people who are survivors of sexual assault. So really kind of opening up and normalizing sexuality for all people, all bodies, all ages. Because again, that sociology part of biopsychosocial is only certain people are allowed to be sexual. You have to be a certain age. You have to look a certain way. That's all made up. And so really opening that up to everybody. There's a lot of work being done with sexual health in people with disabilities. So, I forget, they were just at a conference I was at. It was like, Clitoral Model. If you go to Clitoral Model on Instagram, they're coming out with a book on perimenopause and sex, and doing a lot with like, what does healthy, normal anatomy look like? Because probably a whole nother podcast episode, but the amount of women who don't know what normal bodies look like because our images have been banned on the internet, and then they go in and they literally have cosmetic surgery to fit a fake ideologic normal pattern. To me, that needs to be talked about. I think education will go a long way into body acceptance.
Do you encourage your patients to like get a mirror and have a look at their body parts?
Absolutely. Yeah, absolutely. It's tough. You do need a mirror for some of these parts. Um, but just in exploring people's discomfort with that idea of like, do you have a problem looking at your elbow? No. Right? Of like, okay, isn't it so interesting that there's a part of your body you're uncomfortable looking at? Wow, what's that about? Where did that come from? So it's even like just exploring that a little bit. And even if you end up never looking at it, just understanding, oh my gosh, there's a part of my body that society's told me not to look at. That's super interesting.
I will just share an anecdote, but when I moved from being a GP in Northern Ireland to being a GP in Australia, I find it incredibly interesting how Australian children are much more comfortable talking about body parts than children in Northern Ireland are. So
Interesting.
very interesting. So it's obviously very culturally driven.
Yeah. I mean, parents are role models, and people always ask, like, how do you have the sex ed conversation with different ages? And for the young ones, normal anatomic words for our body parts. They can communicate better. They can communicate with their partner better. They'll be able to communicate with their doctor better. So with my children, it's just like, if they say something hurts, I'll say, what hurts? Is it your labia that hurts? Is it your, vulva that hurts? Is it more on the back? Is it your anus? Is it your rectum that hurts? And, not that they need to get it right, but just me normalizing. There's a lot of different body parts down there. And I think a big problem, going to the doctor is people saying it hurts down there. If they don't get an exam, if they don't know what body part it is, they're usually just given antibiotics for a suspected urinary tract infection, right? And there's so much more that happens to our pelvis than urinary tract infections.
Well, I don't know whether you have the same experience, but I think it's very interesting that whenever you do examine a woman as a doctor, they're always apologizing.
Mhm.
So they'll be apologizing that, they haven't waxed, or they'll be they just are so apologetic.
Yeah.
And I think that's another that's probably a conversation for another day, but no one apologizes when I need to listen to their chest.
Right, right. I'm
Or
so sorry I didn't clean my ear today. Yeah, that's right. And that you have to look at it.
Yeah, but they're so, and even after you do their cervical screening or I do an internal examination, they'll always apologize and say, "I'm so sorry that you had to do that. Oh, that must have been awful for you." I'm like, no, like
Yeah.
that's my job.
Well, I mean, thanks for calling that out because I think a lot of people don't realize even that behavior is tied into society telling us that parts of our body are shameful. And we carry stuff with us. I saw a woman, middle age, she was probably mid 60s, and she was there for whatever reason that we needed to do a pelvic exam, and she apologized. And I said, "Listen, I look at so many vulvas that I'll just draw a bell curve and I'll just tell you where you are on the normal scale, right? Spoiler alert, most vulvas are normal." So she said, "Okay." And so her husband was with her. And I'm like, "Listen, your vulva is completely normal to the point that your vulva is completely forgettable to me. I will never remember this vulva, right? It's so normal." And she had had an ex-husband, I believe, tell her how abnormal she was and how unattractive her vulva was. And she decided that that person's opinion was the most important opinion and that she would carry that with her for the rest of her life. And her current husband was like, I told you it's lovely. I told you it's beautiful. Like, can you believe the doctor now? Because I've been telling you this for years." She was carrying this asshole's opinion with her the whole time. And it's like, knowing you're normal matters. Knowing that your body's healthy, but where are you gonna find that on the internet, right? It's banned, it's blocked, it's considered vulgar, and I think that's where Make Love Not Porn comes in, and then all of the websites where they actually can show, like, vulvas are like fingerprints, right? Listen, not all scrotums look the exact same either, by the way, right? Like, we're not Barbie dolls, we're not all supposed to look a certain way.
I loved yesterday you and I were looking at that model, and there was some asymmetry, because I had so many quite young women coming in asking. So in Australia, if you want to see a specialist, you need to get a referral from a general practitioner. So if you want to see a plastic surgeon or urologist, you need me to refer you, and so they will come to me. I've had probably in the last 6 or 7 years. Definitely have had a few young women who've come in and said, "Look, I've checked it out online. I've looked and I know that there's an abnormality. I'm asymmetrical and I want to go and have plastic surgery." But whenever they're checking out the images, I'm saying, "Okay, well, can you show me what images you're looking at?" One, they're either looking at a very, diagrammatic drawing out of an anatomical textbook, or they're looking at pornography. And again, nothing looks completely normal there either. And it is definitely such a, like, I just think it's so sad that people are going to the lengths of having painful surgery
Yeah,
to
yeah.
try and have some kind of cosmetic normal.
Totally. I mean, these are sexual organs. There's nerve endings that can be cut. There's, reports of diminished orgasm, trouble with arousal. Labia are erectile tissue. So it is not to be taken lightly that we're going to trim these away. And by the way, labia go away after menopause with the low hormones, and women are horrified that their labia goes away. So I'm like, okay, we spend years wanting to cut it off, and then we spend years trying to get it back. Can we stop the madness, right? And I'm also very aware of women tend to have less money than men. For us to be spending our hard-earned dollars on stuff that at the end of the day maybe we should be spending our money on something else, versus like, I mean, how many people truthfully are gonna be looking at your labia? Now, that said, there's always can be a medical indication if they're long to the point where it's difficult riding a bike, if during intimacy they're getting pulled into the vagina and causing pain. I'm not saying all labiaplasties, like, to do a ban on it. I'm just saying the unnecessary ones that are not covered by insurance because there isn't a medical reason, and for reasons of miseducation, lack of education, a lack of body acceptance, those are the ones where I'm like, it's quite possible all of those labiaplasties do not need to be done.
Yeah, 100%. Another group of women that I see are young women who maybe have only had one or two sexual partners, um, and they also have very painful sex. So dyspareunia, and it's causing they've actually got a very loving relationship, but they just can't really have sex.
Mhm.
Can you talk to what might be going on there for those
Yeah.
women?
So again, biopsychosocial. It can be multiple things. So seeing a sex medicine physician, seeing somebody who can talk through all of that, because otherwise you're just going to, again, be told, just drink a glass of wine, just do it anyways, try using more spit, all of these things. There's always a sex ed component that I always go back to, because so many people, and the young people aren't having any better sex ed than we had when we were young, that sex begins by putting a hard penis in an unaroused vagina. That causes pain. Hands down, that causes pain. And even young people with normal hormone levels, if you take an unaroused female pelvis and put a hard penis in it, that vagina is not ready. That alone causes pain. So vaginas, when they have proper blood flow, we have erectile tissue down there just like penis owners do, the vagina will actually lengthen and the cervix and uterus will tip back to make accommodations for accepting something. If you don't have that arousal before you put something in there, it can cause pain. And also, if your brain's not turned on, your brain's like, what, is this a tampon? Like, what are we supposed to be doing right now? Like, you have to tell, for lack of better words, warm up the body. Like, don't go run a 10K without like doing it a little bit before you just do a full out sprint, right? But when society tells us and Hollywood movies tell us that sex starts by putting a hard penis in a vagina without any warm up, that's pain. So I always think about that in young women, like what kind of sex are you trying to have? And is your body warmed up for it? There can be tight muscle issues. There can be basically low hormone issues if you're on oral birth control pills. Your vulva can look, for lack of better words, menopausal, because oral birth control pills do tend to block hormones down in the pelvis, especially some of the newer lower dose birth control pills. You can really look like a tight, irritated vulva down there. So sometimes we have to think about other birth control options or adding in vaginal hormones way before you're menopausal. So also the role of the brain, right? Has there been trauma in the past? How's the body image? How is your mindfulness and being able to be present in the moment? So sex really is wonderfully complex, but it takes time to dissect this out. The sex medicine doctors are basically like detectives, right? My friend Rachel Rubin says we're sex detectives. So we've got to figure out what exactly it is. And this is often, it can also be what happens. There are some men, penis owners, with very above average penis sizes. There are some women with very smaller pelvises. Not saying those people shouldn't be together, but to say sometimes the anatomy is a little bit challenging. Nobody ever talks about that, right? So all of that needs to be explored.
We talked about yesterday a little bit about the mismatched libidos. Can you explain to the audience your thoughts on that?
Yeah. I like to normalize mismatched libidos, or what, the experts call desire discrepancy. Because what we tend to do is we tend to make the male level of libido the default. And so the woman's wrong no matter what if she's partnered with a man. So if we have a man's libido at like whatever level 0, let's say, if she wants sex less than that, then she's the problem because she has low desire. If she wants sex more than that, then she's the problem because she wants sex more. She has the high desire. So the woman tends to stereotypically be circled around what this default of normal is. And when you look at that, you're like, well, that's crazy, right? How come we never say that he's the problem? Now we do sometimes when she wants sex more, then he's the problem. Instead of saying like, no two people are ever perfectly matched on anything. Like my husband likes to floss and then brush his teeth. I would like to brush my teeth and floss. Like we are not matched on anything. And so this like societal expectation that you must be perfectly matched with your partner till death do you part is a complete myth that's really hurting relationships. The stereotype awful story is when the man brings his female partner to the doctor and says she has low libido, fix it. And we're like, can we fix you? Right? Like the loving understanding that not everybody needs to match somebody else is where I always start, is just normalize it and then normalize that let's stop blaming the woman for her always being the problem.
What about if you have a happily partnered couple? I've had a few of these, probably in the last 2 years, who've come to me and they said, we're actually very happy. Their children are grown up, but we actually feel like we've had very boring sex our whole lives. We've been together since we were 17 and we're now 50, whatever.
Yep.
any resources or hints or tips of how these people can move forward and have a more enjoyable relationship?
Yeah. Yeah, it's a great question because in medicine, in my career, we spend so much time just getting out of dysfunction, right? Where we're kind of like, oh, it's average or mediocre. Congratulations, you've reached the pinnacle.
Mm.
But there's this whole other level of like, what if it could be exceptional? Like, you work out forever and then you're like, okay, well, what if there's like a next level of fitness? What if there's a next level of cooking? What if there's the next level of, you know, creative writing, right? We're humans. We want to optimize. So really, I love that the conversation is like, hey, let's not call it good enough just to not have pain. Let's not call it good enough just to be okay with our sex life. What if there is this optimization? Um, Dr. Emily Jamea, Jamea, just wrote a book that just got published called Anatomy of Desire. And what I really like about that book is it's answering that question of like, yeah, this is fine. Like, certainly better than all the horror stories I hear, but what if there's the next phase? And people may have heard of what we call the flow state. And the flow state is when you're like really engaged in something that have kind of become a master of, and time stops. Your brain's not thinking of the past or the present. And she basically goes down and knocks out flow state and applies it to sex and what has to be present to really be in flow state with sex, where it is this like transformative, spiritual, amazing thing where time stops. You don't know what country you're in because you're so present with pleasure. So her new book, I think, is fantastic for this. Um, and I hope we're going to get more and more. The Magnificent Sex by Peggy Kleinplatz is another good book. Just basically, she's a PhD researcher, and she was like, hey, who has great sex? And, these people emailed her, and then she interviewed all of them. And the most important thing I think about that book is nobody who said they're great at sex and they love sex, nobody said it's because I have spontaneous desire for sex. Because everybody says like, I just need desire to have great sex. No, most people would say desire has nothing to do with great sex. And her research supported that. If it's, I'm okay to try new things. I'm okay to feel safe and to communicate the need for safety. Safety's horrifically under talked about in playing the role in good sex. Trial and error, prioritizing time, communication is an absolute must. So it's if you research the people who are having extraordinary sex, you could learn from the pros.
And what do you think about those who recommend having like scheduling it? Because we've all got busy lives,
Mhm.
and that you literally have time set aside or do you think that's not really hard? Because it sort of feels counterintuitive.
Well, I wish I had a spontaneous desire to eat vegetables, and I wish I had a spontaneous desire to go to the gym, but we don't always, right? So you have to prioritize, like, I need to have the gym in my life. I need to have vegetables in my diet. And then when you're eating the salad and after your workout, you're like, yeah, this is what I want in my life. I'm so glad I do this, but I don't sit around, scrolling on my phone, drinking coffee, spontaneously desiring those things, right? So you have to put yourself in the context. And that's what scheduling sex does, is it says, this is the time, we're going to block everything out. The Basically, almost everybody believes scheduling sex is good. The people who have a problem with it are the ones who say there should be no pressure to perform. There should be no pressure to orgasm. There should be no pressure to have penetrative intercourse. It's when you put pressure on that block of time that it can become problematic. But what they've found is scheduling sex, especially in that desire discrepancy couple, it takes the pressure off of one person always pursuing, hoping that they're going to get a yes at some point, and the other person always having to say no, and this person feeling rejected. It's like Monday through Wednesday, we're not even going to talk about sex. Thursday, for however many minutes you think is appropriate. And let's remember, we don't rush through other pleasurable things in life, so let's not rush through this pleasurable thing. That's where we're gonna say, "Let's be together, let's connect, let's touch." In the role of non-sexual touch throughout the week is incredibly important. Research has shown that people who just touch non-sexually more during the week actually have more sex. So it's that connection. And I always joke, one final thing is, I always joke there's 2 people living in a house. The person who needs sex to feel loved and connected, and the person who needs to feel loved and connected in order to have sex. They've never communicated that with each other. They're living in the same house and they don't even know.
What's the likelihood of a female having an orgasm with a male partner?
It goes up the more connected and the more long-term relationship it is. So right now, the orgasm gap in heterosexual relationships is about 60% for the woman. The man's clocking in around 98%, 97% of the time he'll have an orgasm. So even in a partnered, loving, long-term heterosexual relationship, she's clocking in around 60% of the time. And that means of all people researched. But if it's hookup culture sex, in America, it's the university drinking culture, hookup culture, she's having an orgasm about 6 to 7% of the time. And for the purists out there, orgasm isn't always the end all be all for pleasure, but it is a marker of prioritizing one's sexual pleasure. So when you see that marker be as low as 7%, I say, what the hell are these women doing this for? They're clearly prioritizing somebody else's pleasure in these relationships. Communication is usually universally not there. And penis and vagina or penetrative sex tends to be the model as to which 70% of women do not orgasm.
Unbelievable. I mean, it really is such a culture, and you do have to wonder what all these young women are getting from this. And is it because they're lonely, or that's what their friends are doing, or
Yeah, I mean, I'm no social psychologist, but to me, it's like it's nice to be desired. It's nice to be wanted. It's nice to be thought of as being sought after and attractive. But if that's part of the game to set yourself up to vulnerable situations, especially when alcohol is involved, it's a losing game for a lot of women.
Kelly, I just want to finish by asking you. I've been so lucky. This is the second time you've been on the podcast. I've watched you present live. I've shared a stage with you. You are incredible. You're funny. You are smart. You're so captivating to every audience. Why do you do this? What
Mm.
drew you to really put yourself in a position where people can criticize you and love you all at the one time?
Yeah, I mean, it originally started again with my patient zero, right? I had a woman crying in my office because of a sexless marriage, and I was told in my training, women are difficult, we're challenging, we'll never figure them out, and we take too long. I was told all of those things, and really, that patient, the lightning struck my brain to say, I don't know. Does anybody know? Was everything I was told true? And really start and it was a point in my career where I was open to learning new things because you get kinda good at what you do and it gets a little dull, even surgeons, that's the way our brain works. So I was ripe to be able to be curious, and that curiosity has kept me learning and being on the forefront of like, man, women's sexual health now is booming more than it ever has been. Menopause now is booming more than it ever has been. Like, I'm just one step I'm, like, catching these trends. I don't know what next trend there is. We have enough work for a lifetime. But realizing, like, at some point I had the knowledge, I couldn't help enough people just by them coming to my clinic in my city, and the suffering is so incredibly profound. It's so like, n nobody wants to talk about this, but as soon as you talk about it, everybody wants to talk about this. The suffering is absolutely profound, and it's a spiritual journey for me. Like, I now truly believe I was put on this earth to change the world. And I'm doing it with friends. You cannot do this alone. Some people are very invested in not being curious, in keeping the status quo the way it is. And we can see them for that, and we can love them for that and say they don't have the vision of the world where it's a different place. We have that vision. And that's what keeps us going because we don't do it for number of followers. We don't do it for number of likes. I don't do it for ad dollars. Those are all just amazing things that happen when how you're presenting is resonating with the world. And to me, I'm like, would keep doing sex is too interesting to ever be done talking about it. And there's always more coming out. So it's a wonderfully intellectually challenging thing, which keeps me engaged too. And I love making people laugh.
You're very good at it. What piece of advice would you give 20-something Kelly if you could talk to her?
Oh God. Um, it's gonna be really fun. Like, your hard work paid off. The world is big. Um, I mean, even 5 years ago, Kelly, if you would have been like, "Hey, you'd be quitting your job to open up a clinic, to speak on the Sydney Opera House stage, to be on your second book, to have the top 5 medicine podcast on Apple," like, I would have not known how to do that. I would have believed her, and I would have been like, "Buckle up, enjoy the ride," you know? So I'm happy to be here.
It's very clear that you're definitely enjoying the ride, which is awesome. Thank you so much.
Thanks for having me.
This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.